Hi, so my name is Tim Martin, and today we're going to be delivering an in-service for existing emergency room nurses to be delivered at maybe a skills lab or around the table during shift huddle over the course of a week. We're going to be talking about pneumonia, and the reason this is going to be delivered to emergency room nurses is because it's one of the principal admitting diagnoses that we experience. I think sometimes we take a lot of things for granted where pneumonia is concerned, and we need to review, just refresh the latest and greatest as far as pneumonia and the basics every once in a while. So, we're going to have three learning objectives for this lesson. The first will be that the learner will identify at least four different kinds of pneumonia of the seven or eight that we kind of categorize as being out there. The second objective will be that they will be able to describe the two major deficits that result from pneumonia, and these would be part of the pathophysiology of it. And then lastly, they'll be able to identify the best treatment for pneumonia, which, while there are many things that we do to treat pneumonia, there is clearly one that stands above the rest. So, pneumonia, what is it? It can be defined as any inflammatory process that causes the alveoli in the lungs to become filled with fluid and or blood. And this happens for a variety of reasons, so many so that we've taken to not even trying to identify what's causing the pneumonia to begin with. Instead, we classify it as where was the pneumonia acquired. And so we've got community-acquired pneumonia, which is any pneumonia that happens outside of a healthcare facility and that isn't related to a chronic patient's respiratory troubles or comorbidities. We've got healthcare-associated pneumonia, which is the kind that you might pick up at the doctor's office or a radiology clinic or outpatient situation. Hospital-acquired is specifically that pneumonia which comes from was not present when a patient was admitted to the hospital and then becomes present while they're there. A lot of times this will happen to ventilated patients because they're just not breathing the way that they would normally and their lungs aren't working right, and so pneumonia develops. There's aspiration pneumonia, chronic pneumonia for COPD patients, people with tuberculosis, necrotizing pneumonia, and also immunocompromising pneumonia. So the pathophysiology of pneumonia is this. Normal gas exchange occurs in alveoli between the pulmonary circulation and the alveoli, and O2 gets into the bloodstream and CO2 comes out and then is exhaled. This gets impaired when the alveoli become filled with fluid and or blood because their pulmonary membranes have been weakened due to inflammation relative to the infection that's causing the pneumonia. And this limits the alveoli and then consequently the lobes and the lungs' abilities to exchange gases properly, reduces ventilation perfusion ratio, and then also reduces the surface area for gas exchange, which can be very problematic, especially if there are lots of comorbidities, which is many times why pneumonia becomes such an issue for people. The two principal deficits that result from pneumonia, this is one of our objectives, are that there is hypoxemia, which is a low blood O2, and hypercapnia, which is an excess of CO2 in the blood, and these can be determined from any number of blood tests, ABGs, VBGs. You get CO2 just in a chemistry. So the infection that causes the pneumonia is typically generated by a bacteria, and this can be any number of bacteria. There are lots of them that do it. For community-acquired pneumonia, the principal one is Streptococcus pneumoniae, and it's everywhere in the world, on the planet. People get it. And if they're not able to fight it for whatever reason, it causes pneumonia. In the hospital, the principal bacteria that's responsible for pneumonia is Pseudomonas aeruginosa. And then it doesn't have to be bacteria. A viral infection can also cause pneumonia. If the body is working hard enough to breathe due to like really bad flu symptoms or even just an upper respiratory infection or something, then it can cause pneumonia as well. So the pneumonia affects a few alveoli to begin with, and then as it spreads to neighboring alveoli, and then into a whole lobe, we call that consolidation, and then it can even spread to an entire lung or even both lungs in the case of what we would call like a complete whiteout. Signs and symptoms of pneumonia that should bring people into the emergency room and that nurses should recognize would be shortness of breath, especially dyspnea on exertion, a fever that accompanies that same thing, persistent and productive cough as the sputum that comes from the cough becomes more and more colorful dark green, brown, yellowish, going from white and frothy to any of that stuff. And then thick and tenacious secretions are also a sign of later pneumonia. Pleuritic chest pain can be a later sign, especially if there's been a lot of coughing going on or if they're just really having a hard time getting the lungs to inflate fully. Abnormal breath sounds, you hear all kinds of things with pneumonia. Wet, rales, crackles, diminished, wheezing, can be any number of things. So, those are the signs and symptoms that we should learn to recognize. Diagnostics for pneumonia. The chest x-ray is still the gold standard for initial diagnosis. It's the way that we can tell whether or not the lungs are inflating properly or not, or if there's something that's solid that's keeping them from being able to do so. There's a lot of blood tests that we use to look for pneumonia as well, like elevated white blood cell count, low blood O2, high CO2, again, that hypoxemia, hypercapnia that we talked about. Procalcitonin, good marker for infection, and then also lactic acid, if for gas exchange is being impaired, that can help. And then once we know that there's pneumonia, and even most times in the emergency room, if we suspect that there might be, we're going to go ahead and draw blood cultures. And if we can get one a sputum culture, that's to help with accurate organism identification so that we can treat the infection with the appropriate antibiotics. So, on to treatment. Antibiotics, antibiotics, antibiotics. That is the first line of defense against pneumonia, and typically the sooner that the patient starts getting them, the sooner they start to feel better. 48 to 72 hours is usually what it will take to clear an otherwise healthy person, or at least get them started clearing up. We need to be proactive as far as managing symptoms as well. So antipyretics, analgesics, O2 as needed. Increase fluid intake unless you're at risk of putting somebody in some fluid volume overload because of their CHF. And then just some miscellaneous things about pneumonia that emergency room nurses should know. A lot of patients think that if they got the shot, they think that they're immune, and that's just not the case. The Pneumovax is the vaccine for pneumonia. It's given to patients 65 or older, or if they're high risk, and it's repeated after 5 years unless you get it the first time after age 65, in which case you're covered. It is only good against one of the bacterial strains that causes pneumonia, and that's the Streptococcus pneumoniae that causes most of the community-acquired pneumonia. And then again, pneumonia either comes from aspiration or inhalation of the offending organism usually, and prevention involves good cough etiquette, hand hygiene, as well as healthy living habits such as don't smoke, just don't smoke. So review questions that the students in this test are going to have on a piece of paper at the end of the presentation so that they can get credit for the Skills Lab checkoff for this review. Will encompass all three objectives. The first one is which of the following are common classifications of pneumonia, and there's a list of all the different kinds as well as two that are incorrect. Community center delivered is just not a kind of pneumonia, it's community acquired. And then vaccine related pneumonia doesn't exist either. Review question number 2 would cover the second objective, and that is what are the two major gas exchange problems that result from pneumonia? The correct answer being out of 4 that are given here, some that involve potassium and sodium just to throw things off. But the correct answer is, as we've stated several times, hypoxemia and hypercapnia. And then the third question is, what's the best initial treatment for pneumonia? And of course, that's going to be antibiotics as opposed to breathing treatments, antipyretics, and the Pneumovax, which are the other answers that are listed for that question. Speaking of questions, the ones that I would expect from my audience would be, how do we know what antibiotics to give? And the answer is that doctors use a very comprehensive table to determine the empiric course of treatment until the cultures are developed and we know exactly what the bacterial infection is coming from. And those empiric tables have proven to be very effective against the vast majority of pneumonia infections that need to be treated. Our readings and source material comes from 3 different textbooks. One is just a med-surg nursing book, the other one is a pathophysiology book, and then the third is a handbook to another pathophysiology book, which has a lot of the latest and greatest information about pneumonia. And so, I think that we've addressed all 3 of the objectives through both the content of the lecture and the questions and the evaluation. And I thank you for listening to my presentation.